Hello, welcome to the BOS Advanced Spine course on scoliosis, and the topic for the day is Lenke Rule Breakers. Everyone is familiar with the King and Mo classification, but nowadays this classification is not in vogue and is replaced by the Lenke classification. However, I would like to argue that without knowing the concepts of the King-Mo system, one cannot fully understand the Lenke classification, especially if you have to understand the rule breakers. Therefore, I encourage all of you to get hold of this original paper which I have uploaded in this Google Classroom and read it in its entirety. When you read the paper, you'll realize that the purpose of this paper was to test Mo's teachings and concepts. This was not meant to be proposed as a classification. So the key concepts that emerged from this classification was that some double curve patterns or S-shaped curves could be treated by selective thoracic fusion, and this actually lies at the heart of John Mo's legacy. Now, this term selective thoracic fusion is used very loosely nowadays. It does not apply to C-shaped curves. Mo never meant it for a C pattern curve. It only applies to S-shaped curves where both curves cross midline. And basically the key is to identify the lumbar curve as a compensatory curve so that it can be spared of the fusion. This has caused great deal of controversy over the years, and many of the Lenke rule breakers I am going to discuss today are involving this controversy. To recapitulate, the King 1 curve is a S-shaped curve. Both curves cross the midline. On the standing X-ray, the lumbar curve is a larger curve than the thoracic curve, and on supine bending films, the lumbar is more stiffer. Clinically, the scoliometer readings are larger for the lumbar prominence than the rib prominence. So this is called a true double major curve, and in this patterns, both curves are fused. For the King type 2, which is called the false double major curve, again it's a S-shaped curve, both curves cross midline, but on standing the thoracic curve is larger than the lumbar curve. On supine bending films, the lumbar curve is more flexible than the thoracic curve, and clinically the rib prominence is much larger than the lumbar prominence. And in these kind of patients, you could potentially do a selective thoracic fusion. Since 1960s, most teaching was this concept that a mobile lumbar spine is better than a stiff but a straighter lumbar spine. Here is an example from Mo's textbook from 1994. It's a 10-year-old girl treated in 1979, 24 thoracic, 33 lumbar. This child was braced, but 3 years later when she was 13-year-old, the curves progressed. Now it is a 56-degree thoracic curve that bends down to 34 degrees, that is a 39% correction, and a lumbar curve that is again 56 degrees that bends down to 12 degrees, which is 79% correction. Today we'll call this a Lenke 1C curve. If you calculate the flexibility index, which is the flexibility of lumbar spine minus thoracic spine, 79 minus 39, 40, which is a positive integer, and that's why King would classify this as King's type 2. Here you can potentially do a selective thoracic fusion. The stable vertebra for the thoracic curve is T11, and that's why the fixation has gone down to T11 as a selective thoracic fusion with a Harrington rod and a Lucky construct. And 8 years post surgery, the lumbar spine has automatically self-corrected, and this child has a good balance, leaving this lumbar spine mobile. So the other important revelation of this classification was that for single thoracic curve patterns, it identified two variants. The first was a long thoracic type where the L4 was tilted to the right, which is called the King's 4, and the double thoracic type where the left shoulder was higher, and that was called the King's 5. And this classification remained the gold standard for 20 odd years. But the problems with King and Mo system was that it had fair to poor inter-observer reliability, and this was mainly because of the differentiation between King 2 and King 3, whether the lumbar curve crossed the midline or not, and a lot of people used King 2 and King 3 interchangeably. So that was a big bugbear of this classification. It ignored the sagittal plane and became a 1D classification, and we know scoliosis is 3-dimensional. It was non-comprehensive as it did not include thoracolumbar and lumbar curve types, and the treatment guidelines were applicable to the Harrington distraction-based systems. So basically, it was not a good communication tool. But if you read the original paper, you will find that the paper was not designed to be proposed as a classification or a communication tool. It was to prove or disprove Mohs teaching of selective thoracic fusion and the concept of a double thoracic curve pattern and a King's 4 curve type. Then came along this man, and Dr. Lenke and the harm study group has advanced our understanding of AIS more than any other person or group in our times. And he proposed a classification which has 6 curve types, and it was much more comprehensive. The thoracolumbar and lumbar curves were included. It became a 42 curve pattern classification, and it forced one to look at the sagittal plane. It had good inter-observer reliability, making it a good communication and a teaching and a research tool. We know that the curves are classified into different regions, and we also know about the structurality criteria that Lenke classification proposes. But you wonder, where do these numbers come from? The 25 degree and 20 degree is an arbitrary cutoff arrived by consensus by the harm study group, because it was measurable as a reliable cutoff. This is not backed by any evidence. And this is one of the main criticisms of the Lenke classification's definition of structurality. And it is also one of the main reasons why we break Lenke's rules. Coming to the lumbar modifiers A, B and C. Why was there a need for a lumbar modifier? This was put in the classification to clearly differentiate King 2 from King 3 curve pattern, where the maximum inter-observer reliability was observed with the King system. Before the Lenke classification, many of the B modifier curves were called the King 2, which is not correct. A King 2 pattern is a C modifier curve. Actually, B modifier is a little bit larger A modifier curve, and clinically differentiating between A and B does not make a much of clinical significance. These lumbar curves A or B won't be fused anyway. The second modifier is the sagittal thoracic modifier, and this is well and good because this was ignored by the King system. And Lenke tried to incorporate the third dimension, the axial rotation modifier, in the classification, but they failed. Radiographic measurements for rotations were too unreliable with a lot of inter-observer variability, and hence Lenke classification scrapped this, and Lenke classification remains a 2D classification rather than a 3D classification. And these were the assumption made. These were the rules. The largest curve or the major curve was always fused. It recommended to fuse the minor structural curves, and it left the non-structural curves unfused. So the Lenke classification tells us about the regions to be fused for various curve types. However, if we follow these recommendations strictly, then we are doing a disservice to John Mohs teachings. So in 2002, Lenke groups published these series of patients that were treated with the Lenke classification. Out of 106 AIS patients, 546 cases were fused according to these rules. Means that 60 patients were patients where these rules were not followed. Out of the 65 patients with Lenke 1C, where the rule says to do a selective thoracic fusion, 25 patients had a non-selective fusion. Out of the 69 patients with a Lenke 3C pattern, where the rule says do a non-selective fusion, 7 patients had a selective thoracic fusion. 10 years later, they published another series with a larger number of patients. Here you have 1310 AIS patients, and they had 191 patients as rule breakers, about 15%. So if you see in this, the Lenke 3, 4 and 6, the more rarer subtypes, which are about 13% of the total number of cases, but are also the typical S-shaped curve patterns, the Lenke classification did not help reduce the number of rule breakers in this group. So for these rule breakers, the surgeons are still applying Mohs teachings. The Lenke classification did not change the way we treat Lenke 3, 4 and 6C curves. So what are rule breakers? Not fusing a structural minor curve or Fusing a non-structural minor curve is a rule breaker. Means you are not following the Lenke classification rule recommendations, and these are the rule breakers. The reason for the rule breakers is that Lenke classification is not perfect. It does not recommend specific levels of fusion, the UIV or LIV. It does not take into account the clinical appearance of the patient or the sexual maturity of the patient. The structurality rule, as we have discussed, the 25-degree rule, is very arbitrary. Rotations are not included in the classification, and there is no provision made for King 4 pattern, which is approximately 9% of the total number of AIS patients that we see, and this accounts for a lot of rule breakers. So the Lenke classification has recommended further modifiers. The third modifier is the concept of the last touched vertebra, and this gives a good idea where the last instrumented vertebra should be. It is the most distal vertebral level that is touched by the central sacral vertical line, and in this patient it is the L1. A more commonly used variation of the last touch vertebra is the last substantially touched vertebra, where the most distal vertebra whose pedicle is touched by the central sacral vertical line is used as a marker for the lowest instrumented vertebra, and in this patient is again L1. Now there is a fourth modifier that is added by the Peter Newton's group, and the AR modifier divides Lenke 1A into two types. If the L4 is tilted to the left, then a Lenke 1A curve is classified as a Lenke 1AL, which is very similar to the King's 3. And if the L4 is tilted to the right, then it is called the Lenke 1AR curve, which is similar to the King's 4 type, also the long thoracic type. Now let's look at individual Lenke curve types. How do you determine the LIV? Now in this patient, who is a 16-year-old female, 56-degree thoracic curve bends down to less than 20 degrees on fulcrum bending X-ray. The lumbar fractional curve almost straightens out. If you look at the left bending X-ray, it is tempting you to go higher on your LIV, which is this curve pattern. If you look closely at L4, it is tilted to the right. So this is actually a Lenke 1AR or a King's 4 pattern. Here if you see the last substantially touched vertebra, the last substantially touched vertebra whose pedicle is touching the central sacral vertical line is the L3. So your instrumentation has to go a little bit lower down to L3, and you should not cheat higher, like how the bending is tempting you to cheat. So the reliability of correctly identifying neutral or end vertebra or stable vertebra is not very good, and hence I like to use the last touch vertebra or the last substantially touched vertebra as popularized by Dr. Lenke. So if you have a Lenke 1AL curve where the L4 vertebra is tilted to the left, your instrumentation has to go down to the last substantially touched vertebra, which in this case is L1. L1 is also stable -1 vertebra, which you can use another way to know the last instrumented vertebra. So if your instrumentation goes down to L1, you will have a good result. For Lenke 2AR curve or 2AL curve, which are double thoracic curve pattern, again the LIV recommendations remain the same as Lenke 1, which is the last substantially touched vertebra. For Lenke 1B or 2B curves, which are B modifier curves, as I said before, B modifier curve is just a little bit larger A modifier curve. So the decision does not change much. You are never going to fuse the lumbar curve. The B modifier curves are not fused anyway, and you might want to make a slight change in your LIV and choose a stable vertebra rather than the last substantially touched vertebra as your LIV if they are different. So in this patient, the last substantially touched vertebra is D12, stable vertebra is L1. So you don't want to lose sleep over choosing whether it should be T12 or L1, because at this region it hardly ever matters. So in this patient, it would be better to go down to L1 or the stable vertebra. In all double or triple curve patterns, essentially 1C, 2C, 3C or 4C with a C modifier curve, one needs to ask a question: is selective thoracic fusion possible? So if you do a selective thoracic fusion, for a Lenke 1C or 2C, you are actually following the rule as recommended by the classification. But for a Lenke 3C or 4C, if you do a selective thoracic fusion, you are breaking the rule. If you do a non-selective fusion, which means that you are fusing both curves, if you do that for Lenke 1C or 2C, you are actually breaking the rule. And if you are doing that for Lenke 3C or 4C, then you are actually following the rule. So here the main funda to understand is that those lumbar curves which are especially prone to decompensation after selective thoracic fusion tend to have structural characteristics that resemble or exceed those of the main thoracic curve. So they are larger curves, they are less flexible curves, they have a substantial rotation and have a larger deviation from midline compared to the thoracic curve. So these curves should not be left alone and should be fused. So for this, you have to take into consideration these four factors: radiographs, which are standing radiographs and bending radiographs, clinical examination using a scoliometer, maturity marker assessment, the Reser's sign and the triradiate cartilage, and also you need to understand the expectation of the patient. So we'll see one by one. The first is the standing film. On the standing film, on the AP view, if your thoracic curve is larger than your lumbar curve by 20%, then the ratio of the thoracic curve to lumbar curve becomes more than 1.2. And if your apical vertical translation, that means the translation of the thoracic apex, is 20% more than the lumbar translation from the central sacral vertical line, then again the ratio becomes more than 1.2. And in these situations, you can potentially do a selective thoracic fusion. Apical vertebral rotation is very difficult to measure on radiographs, so most of the time this is ignored. And on the lateral view, obviously you should not have any thoracolumbar kyphosis to be able to do a selective thoracic fusion. So essentially this means that if your apical vertebral translation is more than 20% that of the lumbar curve, then you can potentially do a selective thoracic fusion, provided that the thoracic curve is 20% larger than your lumbar curve. So these were the recommendations given by Lenke, and this is how you calculate the apical vertebral translation. Now on supine bending films, you want to check the flexibility of the curve. So here in this example, you can see the lumbar curve is correcting from 57 degree to 22 degree. So the percentage flexibility of the lumbar curve is 64%, and of the thoracic spine is 57 to 35, which is 57 degrees minus 35 degree divided by 57 multiplied by 100, which gives 38%. So you get the lumbar spine which is 64% flexible and thoracic spine that is 38% flexible. And if you subtract the two, you are getting a positive integer. It is called the flexibility index. This was described by the King and Moe classification. So if you have a positive integer, here you can do a selective thoracic fusion. But if your flexibility index is a negative number, then you really cannot do a selective thoracic fusion. So second point is to look at the clinical appearance. So you have to do these scoliometer readings. Like in this patient, you can see the thoracic prominence measurement is lesser than the lumbar rotation measurement. So if you put a scoliometer on the thoracic prominence, it measures 15 degrees. But if you put the scoliometer on the lumbar prominence, it measures 25 degrees. And this indicates that your lumbar prominence is much larger than your thoracic prominence, and such kind of patient should not undergo a selective thoracic fusion. The second point that you want to look at in clinical appearance is where the plumb line falls. In this patient, the C7 plumb line is falling to the left side of the patient, which indicates that your lumbar curve is the predominant reason why this patient has developed a decompensation. Whereas in this patient by Dr. Lenke, here if you drop a C7 plumb line, it is falling to the right side, which means that the thoracic curve is the major component of this patient's displacement. And such kind of patient is an ideal patient where you can do a selective thoracic fusion. So if your thoracic trunk shift is larger than your lumbar waistline asymmetry, again this patient is suitable for a selective thoracic fusion. So the third point is skeletal maturity. If you do selective thoracic fusion in immature children, which are either 0 or 1, with open triradiate cartilage, you risk progression of the lumbar curve. And in these patients, you have to be careful of doing a selective thoracic fusion. If you do that, you can have a progression of the lumbar curve, and hence if you ever do it, you will have to brace the lumbar component of the curve and follow it up till maturity. The fourth aspect is expectation. What does the patient expect out of the surgery? If the patient is not willing for a cosmetic outcome that can leave a lumbar flank crease behind, then you should not offer the patient a selective thoracic fusion, because selective thoracic fusion may leave a small lumbar crease behind or asymmetry behind. If the patient's expectation is more to be part of sport in school, or the patient is playing competitive sport where mobility of the lumbar component is more important to that person, then you may offer them a selective thoracic fusion. So expectation is an important aspect of choosing selective versus non-selective. So you will have to individualize every curve pattern. So take this example. This is a 12 plus 6-year-old female, again taken from the Lenke paper from Spine 2003. The 58 degree thoracic curve bends to less than 37 degree, and a 43 degree lumbar curve bends to less than 17 degree, and this is classified as a Lenke 1C. So there is no controversy in this. The stable vertebra for the thoracic curve is the T11, the stable vertebra for this is T12 L1 disc. So if you have the disc that is stable, then you choose the lower vertebra as the stable vertebra, which in this case is the L1. So your selective thoracic fusion is going down to L1. You have left a 15 degree thoracic curve behind, which is compensated by a 18 degree lumbar curve, and it has spontaneously corrected and to give a good result. So you have followed the rule here, and that's for the Lenke 1C. But this example, 13 plus 6-year-old female, 88 degree thoracic curve bends to less than 56 degree, 64 degree lumbar curve bends to 30 degrees, and this would be a Lenke 3C curve pattern. The classification is telling you to do a non-selective fusion, fuse both thoracic and lumbar. But let's see if we can do a selective fusion in this. So first look at the ratios. You can see that the cob, the 88 degree cob versus 64 degree cob, it is 20% more than the lumbar cob, and the ratio is more than 1.2. Apical vertebral translation is again 2.6, which is quite large. So the apex of the thoracic spine is much more translated than the apex of the lumbar spine. And if you look at the lateral x-ray, there is no thoracolumbar kyphosis. If you look at the flexibility index, the percentage correction of the lumbar curve is 53%, and percentage of the thoracic curve correction is 36%, which means that the lumbar is much more flexible than the thoracic spine, and the flexibility index is positive. If you drop the C7 plumb line in this patient, it is falling to the right side, which means that the thoracic curve is a larger reason for the patient's trunk shift. If you look at the rotations, the scoliometer readings show that the thoracic prominence is much larger than the lumbar prominence. So all in all, this patient has all the criteria where a selective thoracic fusion is possible. So in this, Dr. Lenke does a selective thoracic fusion. The lowest instrumented vertebra is the stable vertebra, which for the thoracic curve is L1. So the instrumentation stops at L1, and you get a spontaneous lumbar curve correction with a very good result. So that is a rule breaker. So the LIV for a selective thoracic fusion is the stable vertebra. So for a thoracic curve, the stable vertebra is the D12, that is the most closely bisected by the central sacral vertical line. If the disc is stable, then the caudal vertebra is chosen as the stable vertebra. So here you do a selective thoracic fusion to D12 and to get a good result. This is a 12-year-old girl who is 1.5 years post menarche. You can see a 71 degree thoracic curve bends to 50 degree. The lumbar curve 54 degree bends to 28 degree, which means that this is a Lenke 3C curve pattern. The proximal thoracic curve is not structural. The percentage lumbar correction is 48%. The thoracic percentage correction is 29%. Means that the lumbar curve is much more flexible than the thoracic curve. Clinically, if you see, the central sacral vertical line falls a little bit to the right side, indicating that the thoracic one is the larger curve than the lumbar curve. The rotations, if you see, the lumbar prominence is 4 degrees, much lesser than the rib prominence, which is 30 degrees on the scoliometer reading. So overall, this patient satisfies most criteria for a selective thoracic fusion. So here you want to do your instrumentation down to the stable vertebra. In this patient, the stable vertebra is L1. So the instrumentation goes down to L1. When you're doing correction, you don't forcefully correct the main thoracic curve beyond the lumbar curve's ability to compensate. Otherwise, you will get a decompensation. So you will notice that I have corrected the main thoracic curve to a lesser extent and to get a harmonious balance between the thoracic and the lumbar curve correction. This is an example of a non-selective fusion that we have seen before, and here the main controversy for LIV is whether you are going to do an L3 LIV or an L4 LIV. So in general, the rule is that your LIV should be the end vertebra. So if you have to choose between L3 or L4, if your L3 is the end vertebra and it is touched by the central sacral vertical line, then you should stop at L3. If your L4 is the end vertebra and it is touched by the last touch by the central sacral vertical line, then you should stop at L4. But what if your L3 is the end vertebra and it is not touched by the central sacral vertical line? Here it's a bit of a controversy. You can still stop at L3, but you will have to take into consideration a lot of factors like bending x-rays, traction x-rays, and overall the L3 centroid should not be more than 3.5 centimeters away from the central sacral line for you to be able to squeeze the LIV to L3 in this situation. In another situation where your L3 and L4 disc is parallel, here the L3 is the end vertebra, but L4 also is end vertebra because you will measure the same curve angle if your L3 and L4 disc is parallel. So if your L3 and L4 disc is parallel, Lenke recommends that it is better off that you stop at L4. In general, in AIS patients, you almost never ever go to L5. By rule, L5 is never the LIV for adolescent idiopathic scoliosis. So the usual controversy is whether you are going L3 or L4. So in this patient, you can see L3, L4 disc is parallel. Here you would measure the same curve angle for the lumbar curve as 57 degree if you choose L3 inferior end plate to measure the curve or L4 inferior end plate to measure the curve. L3 is bending to the lumbar curve is bending to less than 22 degree. This is a Lenke 1C, but you can see on the prone x-ray in general anesthesia, L3 is far away from the central sacral vertical line. In this patient, clinically the lumbar prominence was much larger and the patient did not want to have that cosmetic deformity left behind. So this patient underwent both thoracic and lumbar fusion, and this actually is a rule breaker because the classification is telling you to do a selective thoracic fusion, but still you have done a non-selective thoracic fusion. So coming to UIV quickly, that depends on the shoulder level or the T1 tilt or the proximal thoracic kyphosis, and that's part of another lecture. And just to summarize, if you will stop at for a right shoulder high, you will stop at T4 or T5. Left shoulder higher, you are going to go into the proximal thoracic curve and stop at T2. And if you have level shoulders, you are somewhere in between. uh, but many of these rules you might break. Like in this patient, you have a 36-degree proximal thoracic curve that is bending to less than 25 degree. So according to the Lenke classification, you don't have to include the proximal thoracic curve, but you notice that this patient's left shoulder is higher. So a clinical parameter is overriding the Lenke rules and recommending you to break the rules. So here you will break the rule and go to T2 so that you get level shoulders. Another situation where you will break the Lenke rule, where you will have to include the proximal thoracic curve even if the right shoulder is higher, is if your main thoracic curve, if you have put screws at every single level and completely straightened the main thoracic curve, then you will include the proximal thoracic curve also in it, because otherwise you will cause a decompensation. So if you anticipate a very large main thoracic curve correction, many times you are including the proximal thoracic curve in your fusion, so that you don't get a left shoulder up after surgery. So for Lenke 5C and 6C, for 5C the classification recommends that you do a thoracolumbar or a lumbar fusion, that you will follow the rule. But if you include the main thoracic curve also into this fusion and fuse both curves, then you are actually breaking the rule. For a Lenke 6C, if you are doing both curve fusion, that means including the main thoracic fusion also, then you are actually following the rule. But if you do a selective thoracolumbar or lumbar fusion, then you are breaking the rule. So here for Lenke 5C, if you are doing a thoracolumbar lumbar fusion, you are following the rule, and in this situation you will break the rule and fuse both curves if the patient's right shoulder is higher, which means that the main thoracic curve is structural. If your right side trunk shift is much more, which means that the right side thoracic curve is major component of the displacement. If your lumbar scoliometer reading is equal to or less than the thoracic spine, which means that the thoracic spine is much more rotated, and for the patient the thoracic prominence is unacceptable cosmetic deformity to leave behind. So in those patients you are going to do both curve fusion and you are going to break the rule. For Lenke 6C, the classification is telling you to fuse both curves and include the main thoracic in your fusion as well. But you would do a selective thoracolumbar lumbar fusion and break the rule if you have the opposite. If you have left shoulder higher, if you have the trunk shift that is to the left, which means that the lumbar component of the deformity is much more. If your lumbar scoliometer readings are larger than your thoracic scoliometer readings, which mean the lumbar rotations are larger, and the thoracic prominence, a residual if left behind, is acceptable to the patient as a cosmetic problem, then you can potentially do a selective thoracolumbar fusion and get away without doing a larger surgery. So here in this example you can see Lenke 5C curve, a 70-degree lumbar curve bends to 40 degrees, 40-degree main thoracic curve bends to 15 degrees. So this is a Lenke 5C because thoracic, according to the structurality criteria, is a non-structural curve. There is no thoracolumbar kyphosis here, you can see, but clinically you will see that the patient's right shoulder is higher. Okay, so right shoulder is higher. Whenever right shoulder is higher with a left lumbar curve, then if you correct the left lumbar curve, then your right shoulder will be pushed even higher. So in this patient you have broken the rules of Lenke, and instead of doing only the lumbar curve, you are doing both curve fusion to get level shoulders at the end of your surgery. Thank you very much.